This is Dr. Greenberg. I'm going to be giving a talk on imaging as a prognostic tool in adults with congenital heart disease. I have no financial disclosures. Tutorel, in a recent paper, showed the increase in the number of patients greater than 60 years of age being seen in a hospital in England has been rapidly increasing, as you can see from the left-sided image. Not only has the number been rapidly increasing, but this includes both simple as well as moderate and complex congenital heart disease, as shown on the graph on the right. The mortality for people with congenital anomalies has been decreasing. If you look at the first line and look at tetralogy of Fallot, the natural history is that there's a 70% mortality in the first 10 years of life. Postoperative mortality, however, is reduced to 15% by the age of 36 years. Similar decreases in mortality are associated with atrioventricular septal defects, transposition of the great arteries, and coarctation of the aorta. However, although the patients are surviving into adulthood, the morbidity is increased compared to the general population. There are 2 times the number of hospitalizations in people with congenital heart disease as compared to the general population, and this increases with age. Many of these hospitalizations are associated with complex anomalies such as univentricular heart or tricuspid atresia. If you look at the graph on the right, you can see that the number of adults with severe congenital heart disease is almost equaling those with present in children. The indications for hospitalization are frequently cardiovascular, with 60% of the hospitalizations. The most common causes arrhythmia. However, non-cardiovascular complications from comorbidities occur in 40% of the patients. Adult congenital heart disease has many challenges. Extracardiac complications are common and involve virtually all of the organ systems. Restrictive lung disease is a common complication of congenital heart disease. The patient can have liver disease, particularly those that have had Fontan palliations. Renal disease occurs in half of patients with congenital heart disease, and particularly in patients with cyanotic heart disease. Brain injuries are also associated, both organic and psychological, in patients with congenital heart disease. About half of adult patients with adult congenital heart disease are women, and pregnancy is becoming an increasing challenge to patients with congenital heart disease. Women who become pregnant with a history of congenital heart disease have 6 times the likelihood of thromboembolic disease as women without congenital heart disease. I'm going to focus, however, on primary disease and recurrence and complications of congenital heart disease seen in adults. This chart shows the prevalence of congenital heart disease in adults. You can see congenital aortic stenosis is the most common, but various forms of septal defects and other forms of valvular disease are also common. Another way of looking at this, particularly from an imaging point of view, is to evaluate the patients in terms of whether the aorta, the right ventricle size, or complex palliations are involved. The aorta abnormalities include congenital aortic stenosis and insufficiency, as well as aortic coarctation, but I've also included collagen vascular disease. These genetic diseases frequently present with problems of the aorta very similar to congenital heart disease. Ascending aorta aneurysms can be seen with aortic stenosis and also collagen vascular disease. The left-hand image shows a 41-year-old woman who has Marfan's disease. There is dilatation of the aortic root in this patient. On the right, we see an 18-year-old man who had bicuspid aortic valve, and there is diffuse dilatation of the ascending aorta present. Marfan syndrome is associated with dilatation of the ascending aorta and the development of dissection. Prophylactic aorta root replacement at 5 centimeters in diameter is recommended. The aorta diameter of less than 5 centimeters can also be used for replacement surgery if there's been a rapid growth of greater than 1 centimeter in a year, there's a family history of premature aortic dissection, or there's a moderate or greater aortic regurgitation associated. MRI and CT should be performed annually if abnormal beyond the aortic root. However, if the aorta size is normal, the intervals can be longer, up to 5 years. Bicuspid aortic valve has progression of aortic root and ascending aortic dilatation as well. The mechanism of the dilatation, however, is different. In Marfan's disease, you have cystic medial necrosis giving an intrinsic weakness to the wall. In bicuspid aortic valve, the abnormal flow associated with the bicuspid valve causes some of the dilatation. Some genetic abnormalities are also present in the aorta in the bicuspid aortic valve population, which can lead to dilatation as well. The mean diameter of the ascending aorta in patients with bicuspid aortic valve can increase by up to 2 millimeters per year. Annual follow-up is recommended, particularly if the aorta dilatation is greater than 4.5 centimeters, where there's been a rapid change in aorta diameter or family history of aortic dissection. You can use a longer interval for a follow-up if these factors are not present. So how are we using these recommendations? Well, in a paper published by Verma, who looked at the survey attitudes of surgical management, they found that aortic valve surgery, which is recommended for aorta replacement in patients who have an ascending aortic dilatation of 4.5 centimeters or more, was only performed in 61%. And if there was no valve surgery contemplated, but the aorta measured 5 centimeters in diameter, only 55% of the surgeons responded that they would replace the aorta based on those criteria. So many of the surgeons are not following the criteria that were initially really set up for Marfan's disease. And this may be because bicuspid aortic valve associated ascending aorta aneurysm may not have the same time for replacement necessary. Some people believe that the hinge point is 6 centimeters in diameter before significant increases in aortic dissection occur. Moving more distally to the ascending aorta and the descending aorta, we look at coarctation of the aorta and collagen vascular diseases, which can also be associated with abnormalities of the arch and proximal descending aorta. In adults, we expect that most cases of coarctation have already been repaired, and we're really evaluating patients for their problems with complications of the surgery. On the left, we see a 42-year-old who had coarctation patch repair, and you can see an aneurysm that has developed. On the right, we see a patient with a collagen vascular disease, Lloyd-Steed syndrome, who's also developed an aneurysm of the proximal descending aorta. There are associations with who will develop these aneurysms. Bicuspid aortic valve and patient age are important factors. Oliver found that if you do not have bicuspid aortic valve and have age less than 20 years, there's only a 3% chance of having an aneurysm. However, if you have both bicuspid aortic valve and age greater than 39 years, 50% will develop an aneurysm. This next patient had bicuspid aortic valve with an ascending aorta aneurysm, and the CT was performed for the evaluation of the size of the aneurysm. Recurrent coarctation, which is shown on the right image, was unsuspected prior to this study. Coarctation complication detection is difficult by echocardiography. 50% of the recoarctation cases will have no clinical findings. MRI actually found that recoarctation detection rate was the same for both symptomatic and asymptomatic patients. Since aorta aneurysms are not detected well by echocardiography, and neither is restenosis, that these are inadequate for evaluation. The American Heart Association recommends that lifelong cardiology follow-up be performed. MRI or CT should be performed in intervals of 5 years or less. The right ventricle size plays an important role in evaluation of patient prognosis in anomalies of the pulmonary artery and valve, particularly in tetralogy of Fallot, and in some cases of truncus arteriosus that are associated with pulmonary conduit regurgitation. A valve pulmonary artery replacement is the solution for the pulmonary regurgitation. Pulmonary regurgitant fraction of greater than 25% may indicate a need for the pulmonary valve replacement, but additional factors must be considered, including the right ventricle enlargement, abnormal cardiac function, and a change in the QRS duration of greater than 140 milliseconds, and other associated anatomic abnormalities such as pseudoaneurysms of the right ventricular outflow tract and pulmonary artery. Measures of cardiac function include evaluation of systolic function, right ventricle ejection fraction less than 47%, and left ventricle ejection fraction of less than 55% are considered abnormal. Diastolic function can be detected earlier. We can look for abnormal tricuspid flow patterns, and we can look for late diastolic forward flow in the pulmonary artery. Although diastolic dysfunction is detected earlier than systolic function, it cannot, however, be used at this current time as a determining factor. Measures of right ventricle enlargement have become more important. One way to do this is to look at the end diastolic volumes of the right ventricle and left ventricle and to compare the ratio. A ratio of greater than 2 is considered abnormal and might be an indication for right ventricular pulmonary valve replacement. However, this makes the assumption that the left ventricle volume is normal. Most people, however, have moved on to look at an indexing of the right ventricle. So the right ventricle end diastolic volume index that's elevated may be a better indicator for the need for valve replacement surgery. Various authors shown here have, however, set the threshold limit for remodeling at different levels. So these range from 150 to 170 milliliters per meter square. The trend has been toward using the lower number of 150 milliliters per meter square to do surgery. Finally, complex palliations are present in people with univentricular hearts or hypoplastic left heart syndrome. These people are living into adulthood. There are two wonderful review articles present in the International Journal of Cardiovascular Imaging that have been published in the last year, and I would recommend both of these articles. This patient had a Norwood 3 procedure. All of the connections are widely patent. You can see that the patient has had an extracardiac fontan as part of the surgical procedure. The right ventricle ejection fraction in this patient measured 38%. The right ventricle end diastolic volume was 265 milliliters. The right ventricle end diastolic volume index measured 156 milliliters per meter square. In a recent article by Rathod, looking at patients with enlargement of the right ventricle and complex heart disease or single ventricle physiology, he found that if the end diastolic volume index was greater than 125 milliliters per meter square to the 1.3 power, that there was a poor prognosis. An increased likelihood of death, heart transplant, or listing for heart transplant was found in this group. So in our test patient here, although all the connections are widely patent, the prognosis is not good. In summary, we can use imaging for the aorta, right ventricle enlargement, and evaluation of the univentricular heart size as indications of the patient's future prognosis. Thank you.